Thank you, Graham and Mark, and thank you all to the Prostate Cancer Foundation for the invite, and I'm very honoured to be here on behalf of the New Zealand Urology Nurses Society to talk to you today. As Graham said, we think we've come up with a great idea, and we needed to get some support to get it up off the ground, and Prostate Cancer Foundation have come to the party, so I'll give you all a progress report about where we're up to with that at the moment. The first couple of slides really were just to refresh you all about the different roles that nurses have in this country. We're all governed by the Nursing Council of New Zealand, and there are three different scopes of practice. The enrolled nurse has a 1 year to an 18-month training. They work in all sorts of areas around the hospitals, out in the community and rest homes, and they've had a bit of a resurgence in the last couple of years because they had sort of were dying out a little bit, I think, with funding issues around different health providers. Unfortunately, or fortunately, it's cheaper to fund a healthcare assistant than nurses, although that has changed slightly with the pay parity that the healthcare assistants won last year. Anyway, we do have enrolled nurses, and they are working within urology settings in some areas. The biggest group is the registered nurse, so they do a 3-year degree course at universities or polytechnics around the country, and they're working on the wards providing care. They provide supervision for the enrolled nurses and the healthcare assistants that will be working alongside them. They can practice independently and in collaboration with other healthcare providers. The complication, I think, with the RN scope of practice is it is so broad. It goes from the new graduates that we get straight out of university, right through to advanced practice nurses that are working in roles such as clinical nurse specialists. Just recently, I think, and it was probably about 2 years ago, from Nursing Council decided that registered nurses, if they met the qualifications, could prescribe drugs. So they have to do a postgraduate diploma to be able to do that. And there's a lot of other things that they have to pass before they're allowed to get out there and start prescribing. And then the third scope is nurse practitioner. So that's been around since 2001. There are 301 nurse practitioners in New Zealand now. About half of them are working out in primary healthcare, so they're working alongside in GP practices. Unfortunately, we only have 3 so far in urology, and that's me and Sue, and also Jacinta Townsend. She works out of Counties Manukau up in Auckland as well. So we are all registered nurses to start with. We then have to go and complete a master's degree, and that includes a lot of education in pharmacology because we are authorised prescribers and can prescribe all drugs to do with urology. We have to submit applications and a portfolio to Nursing Council, and then we have to attend an interview down in Wellington. So I did mine a long time ago now, 2005, and I had Stephen Mark, who's going to talk soon, was on my panel. So we have quite a robust process to assess our competency before we're allowed to go out and do what we do. So that at the bottom I can see first specialist assessment. So I work across general urology, so I'm seeing a lot of patients that are coming in with lower urinary tract symptoms, and a lot of you men will know about that. You know, when you get problems with voiding, your GP will refer you into our urology service. The patients are triaged by our urologist, so the appropriate ones will be triaged into my clinic. I can see them, do all the necessary testing, make sure you're on the best medications, review you again. If you're still not doing well, then you'll get referred to the urologist, and you'll have, usually, most of the patients that I send require surgery. Okay, we've got 3 scopes, but if you look at that huge list behind me, you'll see all of the different roles that nurses have throughout hospitals. It's so confusing. You know, we have clinical nurse specialists, and we have specialty clinical nurses, clinical nurse consultants, So a huge range. I'll talk to you a little bit further. We did a study about, I think it's about 8 years ago now, with another nurse practitioner in Australia, and we found there were 35 different role titles for advanced practice nurses working. So huge confusion about who does what, who can do what, whose education allows them to do different tasks. So yeah, clear as mud, isn't it? I'm going to talk a little bit about the research that nurses are doing in the realms of prostate cancer. There's a few headings there. We have two major urology nurses journals, one that's through the British Urology Nurses Society and one through the American. So we submit papers, obviously, and they'll get published. But there's so many, I wanted to focus on sort of what's happening in Australia, New Zealand and Australia as well. One of my colleagues, Helen Crowe, she's a nurse practitioner in Melbourne, and she's looking after the Prostate Cancer Foundation of Australia, the program that they have for training their prostate cancer nurses. And so that was set up a few years ago now, May 2012, so coming up 6 years. And I was actually talking to Steve from the Australian, the Vice President, and my number on this slide from 2016 was 28 prostate cancer nurses, and since this slide was done a couple of years ago, it's now 45. So that's nurses right around Australia in urban and rural centres that are taking up the mantle of providing some of the education and the support for men that are going through prostate cancer. That was just the numbers. So 4,239 new patient contacts through 2015 and 12,000 follow-ups, so people they're just keeping tabs on and checking in with. We don't have that in New Zealand as yet. We have different roles, they're within DHBs though, usually, and some in private practice as well. This was that study I was talking about before that we did in 2009, where we found out there were 35 different advanced practice nursing roles. At that stage, we had 623 urology nurses as a membership of our nursing group. 260 returned our survey, and it shows we're all getting a bit old. And it's a bit of a worry. 80% were over 40. That was 10 years ago, or 9 years ago. So I know I'm over 50 now. So we're sort of not getting any younger, are we? 95% of our group is female. And when we looked at the advanced nursing practice roles, 148 nurses identified within that level of nursing. And this is where the confusion comes in. 45% of roles said they had to do advanced training, like at a university, to be able to do their job. So it's nearly half, so half didn't. That was with the clinical experience of 2 years working in urology, and 59% had the postgraduate qualifications. We asked about training, and I think this will be important for the men in this room. A lot of them have had the digital rectal test when they're going through prostate cancer process. 63 nurses identified that they do that in their day-to-day work, and 19% of them were self-taught. It's a little bit scary, isn't it? When I did my training as a nurse practitioner, I had to do a final practicum year. I worked with a urologist, and I was working alongside him in clinics. And I had to have 50 DREs. I don't know what's better, being self-taught, or the poor men that had to have 50 in my clinic that had to also get checked by the urologist, so effectively they had two. When we're looking at oncology surveillance clinics, so this is men that have had prostate cancer or renal cancer or bladder cancer that are having ongoing follow-up. So in my area, we follow a lot of them out to sort of the 5-year mark. And again, not so many nurses were doing that. That's 21 identified across Australia and New Zealand, and half of them said that they were self-taught as well. 70% of nurses that replied to the survey did think that was could be part of a nursing role, but at a CNS and a nurse practitioner level. This paper was published online for the Nature website, and again, this is from Helen Crowe, the nurse practitioner in Melbourne, and she was commenting on the roles of nursing, advanced practice roles specifically, and she said the number of these roles are increasing because of workload demands. We're all getting flasher technology, robotic surgery, laser surgery for benign conditions. We know our population is ageing. We're keeping a lot of people alive longer, which is great. So we have a higher cancer survivorship. There's competition for the health dollar as well, and how they spend it. And also additional clinics have been popping up over the years, cystoscopy clinics with nurses doing surveillance cystoscopy. The problems that we see is that the levels of education for nurses that are working in these advanced roles are very different, and we have not addressed it properly. There's definitely confusion around who can do what, and acceptance and support of our medical colleagues has been divided at times. This is an example. I was on the specialist subgroup for the Ministry of Health AQUIP project, and when we were looking at developing the clinical guideline for active surveillance, one of the questions that came up is what are nurses doing? Because back at that time, I'm like, well, I'm looking after a lot of these patients, what's happening around the rest of the country. So I did a little survey. I contacted all of the DHBs, there were 20 at the time, and also surveyed our committee to see who was doing what. There were no guidelines anywhere in the country at all in any of the DHBs. Two DHBs said they were under development, and one of them was mine because I was working on the project, so that was only one other DHB at that time. A quarter of the DHBs, admittedly that's only sort of 5 nurses, were working in a clinic looking after men that were having active surveillance. And of those 5, 2 of them had postgraduate training, and that was me and Sue, and 3 were performing rectal examinations, which are one of the mainstays of doing active surveillance. 77% of respondents said that it should be a CNS role or higher. And where should we be seeing them? Should we be seeing them in the hospital or back out in primary health care? And there was a little bit of a split on that with 60-40, with most saying it should be in the hospital. And everybody agreed that we should have a standardised national program, which we do have now with that guideline that was published. And the agreement was about how we train the nurses. So I guess the point I'm making is we've been talking about this for years, dating back to the project that we did looking at who does what, and going on to more recent surveys that we've done of my nursing colleagues. So our recommendations were that active surveillance can be incorporated into CNS or NP roles. This is after initial diagnosis, so we're not out there saying that we'd be, doing the biopsy, telling you you've got cancer, but once the urologist has got that initial plan in place, then you could come under our wing and we could do that ongoing surveillance. Similarly, your GP could be involved with doing that as well. And I think that's very different around the country. Some areas get patients back out into primary health quicker, faster than some others. And we've often been accused in Hawke's Bay, where I'm from, as we keep hold of them perhaps a little too long, but that's just the way the urologists like to work there. And again, national training program to ensure high quality care if nurses are involved in that. I just did this slide to show you from where I come from in Hawke's Bay, 35% of patients that we see back in our urology clinics have prostate cancer. I broke it down even further, whether you can see those little things at the bottom, ADT, so people that are on hormone treatment with Zoladex, people that have had radical surgery, radiotherapy, palliative care, patients that are on watchful waiting, and the little group at the end having had brachytherapy. So it is a big part, that's a third of all of our follow-up that is to do with prostate cancer. So from looking at sort of all the studies that are out there, what we felt, this is a New Zealand Urology Nurses group, the issues that are facing advanced practice nurses now are that we have nothing, there's no accepted national guideline or standard of care, apart from the nurse practitioner role, but we've only got 3 of those. Employers can set up a role as they please. So a clinical nurse specialist, say in Tauranga, could be doing something completely different in her role than one down here in Wellington. There's no standardisation at all. Obviously confusion around the titles. The nurses are confused. I don't know how the public are going to, how they manage as well. I feel if a patient is coming to see a specialist nurse in a nurse clinic, that they should be able to expect that that nurse has excellent and expert knowledge to be able to advise them and talk to them. A lot of the roles are developed in response to workplace need, which is all great. If that service is needed with an advanced practice nurse, I think it would be good if there was some sort of a standard to guide that. But currently, it's ad hoc. We've heard stories from some DHBs that they're putting in a nurse specialist role. This nurse had never worked in urology in her life. So I don't know how that person can go into a clinic. They were saying she would have a clinical guideline. If the PSA was greater than 4 or whatever, then you speak to the urologist. And really, I think that makes a mockery of those of us who are working in other advanced practice nurse roles that have done a lot of training to be able to do what we do to have that happen. Yes. So what are we going to do about this? We developed a proposal of how we wanted to set up a standard of practice for nurses and develop a clinical training program. We first circulated this to our own membership from NZUNS and got feedback from the group about what they thought about putting this in place. We're expecting a bit of controversy, and we were quite surprised that the nursing profession were quite willing and were very supportive of actually taking this on. We didn't have any negative feedback at all, which was great. We've also worked quite closely with Stephen Mark again, getting his view from the USANS perspective, and again he's also encouraged us and supported us along with this process. What the problem was that a lot of us are working full time, and the work that needed to be done to get this training program up off the ground was going to take a bit, quite a bit of input. So we needed to get some funding to get a 0.1 position in place. So we thought our friends at Prostate Cancer Foundation might be keen. They're very supportive of education processes. So we did send a submission to Graham, who took it to the board, who agreed to give us some funding. So we got away, and then we had an application process for the person to do the work, and I got that role, which is why I'm here today. So I got underway in November 2017. So we'll have a little bit of a talk about the 2 sort of main parts of the project. So urology nursing practice standards. We wanted to make it clear what each role of nurse should be doing. And I think it's probably fair to say at this stage, our national body, like the Nursing Council of New Zealand, they do the 3 enrolled nurse RN NP scopes of practice, but what actually happens within those is quite separate to what they're doing. So we can make a recommendation as the leading urology nursing body in this country about our expectations, but it's not written in stone. So we have developed a very confusing graph that I'm going to show you in a minute, but what we wanted to do was to make the standards of practice easy for nurses. Every 3 years, as a nurse, you have to submit a portfolio that shows how you meet the standards that Nursing Council require. So we wanted what we do from the urology profession to slip in easily for nurses in their sort of day-to-day practice. There you go, that is quite busy. I'm only going to concentrate on one part of this, which is what I thought you'd be interested in, which is the prostate cancer clinic, like a nurse-led process. But for this we have, how do I do that? Oh yeah, We've got the enrolled nurses at the top, the registered nurses down below them, and then we've also broken it down into the clinical nurse specialist nurse. And what we're saying, if you're a clinical nurse specialist and you're going to be working in a nurse-led clinic, you should at least have a postgraduate diploma. Part of seeing a patient in a clinic environment, you're looking at them. In some instances, you're examining them, putting hands on them, doing DRE. You should have some postgraduate training for that. We want people to have a clinical assessment paper and pathophysiology to make sure they understand the disease processes associated with the men and the patients that they are seeing. So if we move into the clinical training program, the framework that we're setting up is that just what I've talked about with the training for the nurse-led clinics, that you have a bit of postgraduate training. We also are recognising there are nurses out there that have been in urology nursing for 30 years, 40 years, are going to retire in 5 years, for example. You know, we're not saying you're going to get kicked out of your advanced practice job. You will keep doing that job. This is a recommendation for moving forward. So they'll be doing their university education, but then they'll also be doing some education within the NZUN's sort of framework. And following completion of that, there'll be a final assessment of competency. So these are our proposed initial teaching packages. So we've got 6 on the go. The ones that we've finished so far are actually 5 and 6. I should have reordered my list here. Urology 101. So this is like a new nurse, it might be a new graduate coming into urology. We want that nurse to know the basics, sort of an across-the-board look. So we're going to look at urological cancers, we're going to look at men with lower urinary tract symptoms like benign prostate conditions, urinary tract infection, some of the more common presentations that we expect them to see across the service. So we're talking about nurses working in an outpatient clinic, in a ward environment, or indeed in theatre. So Urology 101 is prostate cancer, bladder cancer, renal cancer, LUTS, urinary tract infection, and I'm sure there's one other I've forgotten at the moment. Now, catheterisation. I'm sure urinary catheters are close to many of the men in this room have had one at one stage or another through their treatment, and you'd be surprised at the different practices out there. So we're setting up a national program that's going to be run, a lot of it will be online, and then we're looking at doing workshops that will be, to start with, at our national conferences, which is going to be in Palmerston North in October, and we're also going to be looking at doing workshops outside of conference time. So we may go down to sort of more rural areas, down to the South Island. The committee needs to decide on our plan of what we're going to do for that. And the third one we have on the go at the moment is for prostate cancer. So that is for nurses that are going to be working in a prostate cancer clinic. And the other 2 at the bottom there that we still have to go by the end of November, when the project is meant to be finishing. So I thought we'd just specifically look at this one, the nurse-led prostate cancer clinic course. So like in my role, what I'm doing is 2 clinics a week. Is purely for men with prostate cancer. So these are men that have had, that are on active surveillance or have had surgery, radiotherapy, etc. So for the nurses that will be doing the training, all of those things on that list is what we want to include in the training. So a lot of that is just the basics, like the anatomy, physiology, also looking at what guidelines, our national guidelines that we've got that they need to be following if they're doing that, and also looking at triaging. Moving on to diagnosis and staging, and remember, these nurses are not making that initial diagnosis. That's done with the urologist in clinic. Physical assessment, so I am checking like the DRE of the patients that are coming through. You need to have a good understanding of all the laboratory results and the imaging that we're getting done. And you can see by the presentation this morning, there's new technology coming out all the time that you need to keep up to date with. And then we're going to be looking at the different treatment modalities for localised prostate cancer and also for metastatic prostate cancer. Drugs with prescribing. I can prescribe now, but some of the RNs will also be able to prescribe, so we want to have specific education sessions about them so they know what to do with hormone therapy, erectile dysfunction, alpha blockers, etc. And then looking at the things that nurses are good at. I know my appointment times I have a bit longer than the urologist has for their clinic appointment time. So I've got the time to be able to sit down with the patient and their partner or their family that comes in with them, and to be able to talk to them about what's bothering them. What can I help with? Looking at sort of all facets of, it's the holistic thing, isn't it? We talk a lot about with nursing, and I do think the patients that I have appreciate that time that can be spent on that. Hooking them up. I've got the cards for the Prostate Cancer Foundation, and I dish them out in the clinic so that they know that they can get support with your group. Talking about scope of practice as well, what people should and should not be doing in these clinics, and I think that is a worry for some of our colleagues in the urology group. So we need to know that how we are working together and collaborating together. They need to know the basics of how to run a clinic, and also cancer survivorship. That's a big thing, isn't it, with any patient that's been diagnosed with cancer. How do you keep going after a cancer diagnosis? So I think a lot of those things are excellent for nurses to be involved with. At the end of this sort of workshop training, the nurses would be expected to work alongside either a urologist or another nurse practitioner with some clinical mentorship, and then they would undergo a final evaluation that would then say that they're ready to go in a nurse-led clinic. They were the types of patients that would be expected to be seen in these clinics. That's a little picture of me, and I think Barry this morning talking about equity. I'm about to get on that little tin can of death and fly up to Wairoa up in northern Hawke's Bay, where I run a monthly clinic up there to see men. So benefits are, I think, that time for that communication, to be able to sit down and really get to the bottom of some problems, education, involvement of the whole whānau, developing of a patient plan and taking your thoughts into consideration about where you want to go. It can allow urologists to focus on higher acuity patients. Sometimes the urologist I work with thinks that's a bit of a bad thing, because he would quite like to see a patient that's ticking along after his radical prostatectomy with an undetectable PSA, and see that patient in his clinic, because it gave him a little bit of breathing space, and now he has to do a lot harder work. And it also is a good contribution to meeting the Ministry of Health faster cancer treatment guidelines as well. It improves job satisfaction. This is the best job I could have. I love my work. I really like, the face-to-face time with the patients and to be able to do that kind of thing. And I'm cheaper, after all, doesn't it? I'm cheaper than a urologist or an advanced practice nurse. So what's next? At our October conference, we will be running our National Catheterisation Workshop in Urology 101. And we'll be having our first nurse-led prostate cancer clinic workshop, and then I'll continue work on those other items here. And I think it's important to recognise it's not just me, like I'm contacting other people within nursing and medical to be able to work through this and get these training programs developed. So, in summary, that's a very busy slide, isn't it? But we want to ensure that we're doing the right thing, especially for you, our patients that we're looking after. We want to have health professionals that are out there, that are well educated, that are providing consistent care. So we're committed to getting and supporting all of our nursing members to achieving that. Thank you.